Good day. It's a pleasure to meet all of you and to speak today about ischemic stroke management at the 18th British-Ukrainian Symposium. For those of you who don't know me, I'm an emergency physician and the emergency medicine practice chair for Mayo Clinic Health System in Minnesota. I work both at academic and large community hospitals, as well as smaller sites with limited resources. So as we begin this lecture today, I will share the best practices in stroke management, but I encourage each of you to see what resources you have based off of the size and availability of your hospital so that you can best meet the needs of your patients. Before we start, I will share that I have no financial disclosures. Now let's imagine a patient case. It's a Tuesday morning, and a 58-year-old man named David is sitting at his kitchen table sipping coffee. Suddenly his arm feels heavy, and his speech becomes slurred. His wife comes up to him, and she asks him if he's okay. He says he's just tired, and they both hesitate. That hesitation costs precious minutes, and by the time David arrives at the hospital, the clock has been ticking for over 90 minutes. In stroke care, those 90 minutes can mean the difference for the patient of walking out of the hospital or living with a lifelong disability. Ischemic stroke has touched many of our lives, whether through family or friends who suffer this illness or as medical providers caring for patients. We recognize the symptoms and we act quickly to provide patients with life-saving care that can reduce both morbidity and mortality. Ischemic stroke is a disease that transcends all of our borders, and it's the third leading cause of death globally. It accounts for 10.7% of deaths, and it is the leading cause here in the United States of preventable disability. Our survivors often face challenges in mobility, communication, and daily activities. And a stroke doesn't just impact their health, it impacts their profession, their relationships, and even their happiness. An ischemic stroke occurs when there is an obstruction in a blood vessel feeding the brain, which reduces blood flow, causing tissue damage and a focal loss of brain function. Today, we're going to briefly mention signs and symptoms of ischemic stroke, then discuss ways we can organize our medical team to respond. Finally, we will share the newest 2026 guidelines put out by the American Heart Association and the American Stroke Association. Every minute during a stroke, 1.9 million neurons die. And while we hope they may resolve in what's called a transient ischemic attack, a temporary blockage in an artery, many of these patients are going to go on to have an ischemic event. In this disease, time is of the essence if we're going to provide life-saving care. So how do we approach the patient with a possible stroke? When we suspect a stroke, we should organize ourselves so that we can act quickly, act wisely, and act as a team. Using a systematic approach, as we should always do when dealing with critically ill patients, we will start with the ABCs. We'll gather history, including when did the symptoms start? Are they on any anticoagulants? Every detail matters here because it's going to help determine whether we can offer the most powerful therapies to help them, such as reperfusion through either thrombolytics or intervention. Physical skills remain critical. Technology helps, but the patient's presentation often tells the story. Using the homunculus, we can localize the affected area of the brain, and we can confirm this on imaging studies. And we want to keep a wide differential. There are many different symptoms that can mimic a stroke, and misidentifying a stroke and treating aggressively with thrombolytics or endovascular intervention can be dangerous. Therefore, it's important to obtain a good history and physical exam. Every stroke patient needs an NIH stroke scale completed. It guides the severity of the illness and also helps us decide on treatment decisions. In the emergency department, our goal is to rapidly assess the patient to see if they are candidates for medicines and therapies to decrease morbidity and mortality. Quality stroke care begins with nursing education. In our emergency departments, we use the BFAST screening tool that all nurses are educated on. This exam allows us to also screen for posterior circulation stroke that is often missed when using other screening tools for stroke patients. Any patient who presents with any of these symptoms will get a BFAST exam. If the deficits are noted by the nurse, they will call for a physician who will confirm the deficit and will call what's known as a stroke code, which mobilizes our hospital resources. Introducing stroke education and rapidly assessing with your nurses in triage, you will identify many more stroke patients earlier, allowing you to intervene more often with life-saving treatments. However, it should be noted that the sensitivity of these nursing and EMS triage tools do vary between nurses and EMS providers. They can be anywhere from 60 to 91% sensitive and 24 to 98% specific. And this is why we really rely on our physicians to confirm the suspicion for stroke. If a stroke is confirmed, we will go on with our stroke process. And if the physician doesn't think it's a stroke, then they can order a different workup for that patient. It is important to have a structured approach to how you care for stroke patients. Here are our guidelines at Mayo Clinic. When a patient arrives, the nurse screens the patient using the BFAST exam. That is, if they have not already been screened positive by emergency medical services. The physician can be notified immediately if either EMS, our emergency medical services, or nursing have found a patient to be positive for a possible stroke. The patient is immediately wheeled to the CT scanner where they will receive a point-of-care glucose study if they haven't already had this done with emergency medical services. This is all done while we're situating the patient inside the CT scanner. Within 15 minutes, the emergency physician is talking with a neurologist, either within the hospital or online using telemedicine. Our radiology team is also immediately notified so that they can look at those images in real time and communicate to us their findings. Meanwhile, the emergency physician is also working with both the patient and the family to screen them using validated tools to decide whether the patient meets criteria to receive TNK, or whether the risk of bleeding is too great for both intracranial hemorrhage or hemorrhage somewhere else in the body. Within 30 minutes, we have decided with our neurology team whether or not to push TNK. Our pharmacy team is also standing by and ensuring proper dosing and helping our nurses to safely administer the orders that we've placed. Within 45 minutes, we have administered the thrombolytic to the patient. We will also perform either a rapid CT angiogram or a rapid MRI to look at large vessel occlusions in these patients. In patients who meet eligibility, we will consider them for endovascular therapy with our goal of having them receive this care within 120 minutes from arrival to the operating room. They will be transferred to another facility if they meet these criteria and no endovascular treatment is available. Throughout our evaluation, we are ruling out other diseases or conditions that place our patient at risk if not corrected, and we're considering our differential diagnosis as we move through patient care. There are many steps we can take to help reduce future stroke risk and decrease current morbidity and mortality for our patients suffering from stroke, beyond thrombolytics and beyond endovascular therapy. So let's discuss the new 2026 stroke practice guidelines. There are multiple trials that suggest superiority of tenecteplase over alteplase, with improvement in reperfusion and functional outcomes. Additionally, as a single bolus over 5 seconds, it reduces delays in care such as transfers or endovascular treatment. And how well does it work? Well, in multiple trials, including the ACT, ATTEST 2, Extend 1A, TNK trials, it showed non-inferiority compared to alteplase, and in some cases showed superiority for large vessel occlusions. TNK achieved higher rates of reperfusion and better functional outcomes in thrombectomy candidates as well. There are many studies that showed that TNK significantly improved excellent functional outcomes compared to alteplase, with no difference in mortality. So given the ease of administration and the fact that there is, again, no difference in risk, tenecteplase is now recommended over alteplase for stroke administration. Recommendation number 2. Thrombolysis is not recommended for non-disabling deficits within 4.5 hours, and instead we're moving to dual antiplatelet therapy. There's also a recommendation for extending the tenecteplase window beyond 4.5 hours with special imaging studies. Now, this is going to be a discussion between neurology, your radiology team, and yourself after screening the patient in the emergency department to decide what is the best method or treatment for the patient, recognizing the risks and the benefits based off of current data, but also looking at imaging studies to see if there is an area of penumbra that can be salvageable. Recommendation number 4. Endovascular thrombectomy or EVT. For patients up to 24 hours after their stroke symptoms started, they may be eligible for EVT if they have imaging studies that show an area of salvageable tissue. Additionally, we're now considering posterior circulation strokes and larger strokes with infarct cores that are quite big as possible candidates for EVT. We do not recommend EVT for medium occluded vessels, and we do support EVT in large vessel occlusions in patients who have received tenecteplase. Recommendation number 5 is for mobile stroke units. Mobile stroke units, or MSUs, are designed to rapidly identify and treat thrombolytic eligible stroke patients in pre-hospital settings. They often have special equipment such as CT scanners and can quickly assess these patients in the field to see if they might benefit from thrombolytic medications. They also enable the team to quickly bypass hospitals towards a larger interventional hospital that can provide large vessel occlusion strokes with endovascular therapies. Which leads me to recommendation number 6. Ambulances can consider bypassing non-stroke capable hospitals to go directly to primary or comprehensive stroke centers. Medical directors for emergency medical systems should devise systems that prioritize centers that can deliver both thrombolytic therapy as well as interventional therapies to patients suffering stroke patients. For those patients suffering symptoms of a large vessel occlusion and within close distance to an endovascular treatment hospital, we would recommend going directly to that hospital over others. And recommendation number 7, for the first time, we have pediatric stroke recommendations as part of our guidelines. We want our EMS or our pre-hospital providers to assess these pediatric patients with neurological deficits. We want them to consider rapid transport to hospitals that can get imaging that will benefit the patient and give them the potential to receive those same therapies we give to our adults, whether it's TNK or endovascular treatment. And recommendation number 9. We want to promote stroke networks for coordinating care, whether it's between hospitals or pre-hospital notification systems. We really recommend figuring out a system that works every time for the patient and monitoring those outcomes. We also recommend tele-neuroradiology for rapid imaging studies so that we can get a quick read on what's going on in the patient's brain and make clinical decisions depending on what they see. So now remember David, the 59-year-old patient who is suffering from a stroke? Luckily, his wife called for an ambulance and he was brought to your hospital, where you knew that emergent imaging and ruling out other diagnoses were important. You carefully considered whether thrombolytics or endovascular treatment was needed, and thanks to your care, he will live another day. So in summary, we want to recognize those early signs of stroke and teach other team members, including emergency medical services and our nurses, how to look for those signs. When they see these signs, we don't want them to be afraid to be wrong. And we as physicians can always confirm whether a patient is having a stroke. Next, we want to create that system for rapid diagnosis and treatment of ischemic stroke in your hospital, and create quality metrics that time you and give you feedback on how you're doing. Where are there areas that we can improve care for our patients and make sure that we are meeting the mark to provide excellent care? And remember that stroke care is evolving, and understand that these are the newest guidelines that were shared today, but they're sure to change in future years. And remember, our pediatric patients also are now included in our guidelines. We want to make sure that our patients are rapidly taken to the best place that can provide the best care for the patient, and always using evidence-based care when possible. Here are my references in case you want to learn more about acute stroke care. Thank you for this incredible opportunity to present to all of you today. Please feel free to reach out with questions. Thank you. And you can find me here on LinkedIn. Thank you.